as a journalist, I was making a film. I was working also for the BBC. And I remember following medics and then being shot at. You're just hearing that a hospital was raided and bombed. You're just hearing that doctors were dragged away and killed and nurses. You're just hearing an entire hospital with its patients killed. We heard about the horror in Sudan.
Yeah.
There's no explanation. It's
Palestine.
just happening.
Will the PhD help unpack some of these things? And what other thing will the PhD add?
I mean, we all want, as academics, our work to be able to have impact and outreach and engagement. But I wanted to use core academic skills and research methods to find the answers myself.
Your PhD seems a bit very heavy emotionally. How are you protecting yourself?
I've cried in many offices. I don't mind saying.
Hello, everyone, and welcome to the ViVa, the podcast where we make research accessible, easy, and understandable. I am Sam Agyapong, a PhD student at the University of Cambridge, and the host for this podcast. In each episode, the promise is that we explain research in a way that a 10-year-old can understand. Today, I'm joined by Saleyha Ahsan. She is an emergency medical doctor, a journalist, an ex-military officer, and a PhD student at the University of Cambridge. Her work looks at what happens when the healthcare is under attack. Welcome, Saleyha.
I'm so thrilled to be here, Sam. Thank you. Thank you for having me. And congratulations on the launch of this amazing podcast.
Thank you. And thank you for being the first guest on this podcast.
I'm very excited.
Yeah. Well, let's dig right in. Tell me about your research.
So I'm looking at the impact of attacks against healthcare in armed conflict.
Yeah.
And I'm doing this within the Department of Engineering. I sit within the International Health Systems Group.
Yeah.
And I'm using systems engineering and systems thinking to try to understand the challenges faced for people who are trying to deliver healthcare in armed conflict, using a systems approach.
Yeah. What do you mean by systems engineering?
So systems, well, when you think about the world around us, everything is built up of systems. You know, I'm an emergency medicine doctor, so using the medical analogy, the body is made up of a whole load of systems. And when I was a medical student, we learnt about medicine via the systems of the body. So whether it was the cardiovascular system or the musculoskeletal system or the gastrointestinal system.
Yeah.
So everything is a system, but it all comes together to form one whole us, a body, a human. And it's the same within systems thinking. I'm still relatively new in this field, but it's where you break things down into their sort of components and look at it from and then look at how the system works together. So, for example, healthcare. Yeah. Healthcare is made up of, and this is just everywhere, not just in an armed conflict or humanitarian setting, but healthcare is made up of people. It's made up of infrastructure. It's made up of different professions. It's made up of different disciplines, from healthcare related clinical specialties to logistics to people who are experts in, procurement. So it's the whole
system.
The whole thing. And that's what I'm trying to do for looking at healthcare delivery in armed conflict, because it occurred to me that, there are so many different factors at play when you're trying to look at healthcare delivery in armed conflict. It isn't just the medics parachuting in or the medics who are already there delivering, but they're reliant on so many other things as well, on the medicines getting in. Well, who's going to help them get the medicines in? Well, it's procurement, it's logistics, it's transport, it's communications. And so I'm trying to look at the whole picture, and the way to do that, for me, makes sense doing it through a systems approach, where I can look at it as a whole system.
As a whole system. Oh, that's interesting. And I like how you've broken this down from my understanding. When you say health attack on the healthcare, what do you mean?
Well, okay, so an attack on healthcare, there's the WHO definition, which I won't sort of recite, it's long and wordy, but essentially it kind of includes anything that could be obstructing healthcare and obstruction on healthcare. And so when you look at the wider and more fuller definition, it's anything that will obstruct and delay or even sort of refuse the delivery of healthcare. And that can be through violence. It can be through obstruction at checkpoints, for example. It can be through just refusal of permission. It could be, it could be verbal, but it's also attacks. So what do we consider an attack? It's an event. It can be a violent event. It can be a verbal. It could be obstructive, as I said. And I'm talking about within an armed conflict setting. But, I work in the emergency department. I mean, we have verbal abuse from patients and maybe, members of the public. We suffer from that from time to time for various reasons. It's not a blame thing. It's just recording the fact that this actually does happen. So that can even be sort of deemed under the definition of the WHO an attack on healthcare. But I'm looking at it specifically in an armed conflict setting. I'm looking at all levels, whether it's verbal, obstructive, denying entry, physical attacks. And physical attacks can be a whole host of things, from a one-to-one person thing, or it can be an entire military force.
Wow. So you've made us understand what the healthcare system is about, what the system approach is about, and then obstruction of healthcare. Now, could you dig deeper in the attack on the healthcare? What do you mean by armed conflicts? And could you give some examples?
So it basically means two or more states fighting against each other, or when one of the states moves into another territory and takes it over, and there hasn't even been a formal declaration of war, so there doesn't have to be. That's an international armed conflict. A non-international armed conflict is when it happens, it reaches the threshold of a conflict within its own borders. So, for example, the state might be fighting against an armed uprising which has crossed over the threshold into an armed conflict. So it involves a protracted armed violence between a state's force and organised armed groups, or between such groups within a state's territory meeting a certain intensity and organisation threshold. So it could even be between two groups, two non-state actors. There's other definitions. I mean, it's broad because not everything sits nicely within a definition. So violence by an organised group, a state or a non-state actor against civilians is often considered a category in its own, so a one-sided violence. That's when, as I said, a state or a non-state actor. When I say a non-state actor, I mean not the official military, but a military force of a country, like the Army, Navy, or Air Force, but more of a group that has become militarized and organised. Might have some form of a uniform, might have weaponry, and it's when they rise up and conduct organised violence against civilians. So that is also considered a distinct category of armed conflict. In terms of other definitions. The WHO doesn't actually have one, and it relies on international human rights and humanitarian law definition.
I see. All right. So if I could explain your research back to you, you are looking at how armed conflict affects various parts of a healthcare system, and you are looking at this through a systematic lens. Wow. What motivated you to do this research?
Oh, that started a long time ago. Okay, really long time
Tell
ago.
me about it.
So I'm ex-military, and I served in Bosnia.
Oh, okay.
And I was in the Royal Army Medical Corps, as it was then. It's now the system in the UK is now changed. It's tri-service between Army, Navy and Air Force. But when I joined the Army, we still had our separate areas. So I was in the Royal Army Medical Corps, and I was deployed to Bosnia, and I wasn't a doctor at the time. I was a non-medical support officer in the Royal Army Medical Corps. And I witnessed, we had to wear the Red Cross emblem. And I was really fascinated by how we were able to move around under the Geneva Conventions, wearing the logo, wearing the emblem.
And no one could attack you guys?
No, and, we had the... no one could... we weren't obstructed. I mean, there were attacks against healthcare, even in Sarajevo, now that I've learnt. I wasn't positioned in Sarajevo at that time. I was in other areas, but it's widely known that in Sarajevo there were strikes against hospitals and personnel at that time. However, it was still different to the way it seems to be quite mainstream now, unfortunately. It was still, I think, then conjured shock and horror and disgust that hospitals were and healthcare were being targeted. Plus, the weaponry that was being used, different to what's being used now. That there it was snipers, there would be shelling. But now it's whole aircrafts flying over hospitals and dropping bombs. Or it's barrel bombs from helicopters that we saw in Syria quite a bit. So I think the weaponry's changed. But in terms what brought me to this was my interest from that time of just noticing that we had ease of access. We were identified as we moved through areas with our uniform, the Red Cross emblem, with our vehicles with the Red Cross emblem. I can see it now, just talking about it, how it was. And the fact that we were explained about the Geneva Conventions before we went out, what they were, what we could and couldn't do. We were carrying weapons, loaded weapons. And
as the medical corps?
Yeah.
Okay.
So I was a non-medic, but everyone carries a weapon in the military, but we have rules of engagement of when we can and cannot. And as medics, when we're considered as non-combatants, and it's for personal safety and for the safety of our patients. And for your, if anyone's in danger, but it's not in a combative way. So what I learnt there were the strict rules of engagement of what we could enjoy, as in who could attack us and who couldn't, and who we shouldn't really. But it also what our responsibilities were as medics and what we had to do and what was expected of us under the Geneva Conventions. And then what I saw in Bosnia as a non-medical support officer inspired me to retrain to become a doctor, and that's what I did. So the plan was to leave the army, to come back in the army as a doctor, but when I left, I retrained, and I then started to go to different countries that I hadn't been allowed to go to when I was in the army, because there are certain countries you're not allowed to go to. You're not allowed to go to active war zones. So whilst I was a civilian, I thought I'm going to go to the places that I've always had concern about or interest about and want to know more. And so I did. I spent time in the West Bank. And this was during the second Intifada, the second uprising. And then I also went to Kashmir. I went to other places. And I saw, as a civilian, how hostile it was towards medics. Even then, in 2002, 2003, I was at that point, because I was a journalist before I joined the army, and I've carried on with my journalism ever since. So when I was in the West Bank, I was actually there in a role as a journalist. I was making a film. I was working also for the BBC, and I remember following medics and then being shot at. I saw it. I caught it on camera. I have footage of 2003, clearly marked vehicles, clearly marked personnel
who are being shot at.
And that was when I thought, whoa, all things are not equal here. And this was, 3 years before I'd been in green uniform with a Red Cross emblem, and it just showed how vulnerable you are when you're a civilian. And actually, to be honest, now today, and I just remember thinking at that time, if we don't nip this now, then all healthcare is going. It doesn't matter if you're in uniform or not, and a civilian or a humanitarian organisation or just your own local national health provider, you're all going to be targets. And that's where we are now. And I think for me, the seeds was so then. And I remember then, I made a documentary at the time, and it was called Article 17.
Article 17.
Doctors in Palestine. That was a documentary I made, and it was supported by the British Council, and it was screened in Cannes. It was really amazing. But it was Article 17 of the Fourth Geneva Convention about access to healthcare in an armed conflict, whether people could be evacuated, etc. And that film just showed how that was not happening. And now you fast forward to now, and it's so to seed. And it's only now that I've been able to, I did my master's in international human rights and humanitarian law, but that was in 2013. I couldn't find, can you believe it? I couldn't find anywhere, and I looked in many, many universities. I couldn't find anyone that would supervise me to look at a PhD on the attacks of healthcare in armed conflict. I just couldn't. But if I was to start now, because of the way of the world, I think I'd find them. So it took a long time for me to find a home. Thankfully, Cambridge gave me that home and that start. But I couldn't, all the places that I'd looked all over the place. I looked in London, I looked at Manchester, I looked at all the, the places that you would think could do this PhD, but I couldn't find a home. And then I did find it within sociology in Cambridge, where I began this PhD. And then it's now evolved to a systems thinking one in engineering. So I'm very grateful that Cambridge kind of saw this as an area of study before it hit the news.
Wow, that's an interesting journey you've had.
It's a long one. Sorry, Sam.
As a journalist, as a military officer, trained to be a lawyer, a medic.
Well, it's all on the subject. It's, in the centre, I'm passionate about the subject of healthcare delivery in armed conflict from what I've seen as a practitioner. And I've tried to look at it from different perspectives, and it all comes down to that one question. I'm just, before I made films about it, I wrote articles about it because I thought that was enough. I thought and that's what journalists do. They want to shine a light in dark areas. They want to bring the truth out. They want to make people aware of what's going on, because then you hope that might have impact. People who are deciding policy, people who are sitting in high office will take note. Public outcry might even influence it. And that's always the hope, that, you will shine a light on something. But I just got a bit, I've showed it again, nothing's changing, it's looking like it's getting worse. And I think that's not just me, but other journalists and filmmakers. And so I wanted to do the next thing. I thought, well, what will help? Do I need a better understanding on the law? I did the law degree. That only took me so far. And then and you're on your PhD journey. I just needed consolidated, ring-fenced time to think about this.
Yeah, my next question would be, will the PhD help unpack some of these things? And what's significant? What other thing would the PhD add to this?
Great question. I think, I'm in the last 12 months of mine now.
Yes.
And I think what it has allowed me to do so far is not to have to squeeze in thinking about this subject when I'm not on an A&E shift or in between other things. It's allowed ring fence, focus, concentrated time. It's allowed me to develop skills in research methods that I didn't have before.
Yeah.
It's exposed me to this world of research and academia that I didn't have access to before.
Mm-hmm.
I didn't understand the whole concept of coming to learn about research methods.
Yeah.
I was very practical as an absolute, hardcore practitioner all the way through. What it's made me do is stop and realize there's just a whole array of approaches and techniques and methods across disciplines to look at some of these questions that we're all trying to answer. And I think that's been invaluable. And I think a PhD is really a unique time to allow you to do that. And I have made the most of it. I've really made the most of going on as many training courses as possible to learn different techniques, because I think, there's multiple ways to look at this. And I think it required me to look at different methodologies and different method approaches for me to find the one. And it's mixed methods now. I'm triangulating different data sets, both qualitative and quantitative, to look at this question of the impact of attacks against healthcare. And they all will hopefully fit together to come up with my findings. And I think in terms of the PhD, it's also allowed me to develop, there's so many things that I've learned in terms of even just the language. I didn't have the language that I have now of how to talk about my subject.
Yeah.
I didn't,
Even as a journalist.
I didn't have the academic language for it. I didn't have the sophistication of academic language and research and a more evidence-based approach, and like the rigor of an understanding of rigor in my work. So journalism, you try to make your work accessible to all. It's a story. You're trying to bring a story to a wider lay audience. Within academia and within my PhD, I've been allowed to go deeper than that. We all want, as academics, our work to be able to have impact and outreach and engagement. We want that. We want public engagement. But I wanted to really use core academic skills and research methods to find the answers myself, to understand them at a deeper level, and then to be able to give that information to a wider audience.
Yeah.
So I think it's also allowed me, there's other things that you get from doing a PhD. Contacts. A PhD is a time to really network and meet people. And it's a really unique time for being...
Like we met.
Like we met, exactly.
Yeah.
There is so much on offer out there. Sometimes it's just a case of the fact that there's so much.
Exactly.
And you have to make sure that you keep your research and your work going as well. But your diary is full. And you're saying, what I'm saying, don't you? Your diary is full. There's so much.
Yeah.
And it's such a journey, and it's just brilliant. I've found I found people willing to talk, people willing to meet for coffee, to discuss things, to share their experiences or their, insights into, a grant that's coming out or an opportunity. And it's almost like half of your time keeping up with all the opportunities.
That's true.
I think that's really important within this PhD time that you have, because you're not going to be exposed to that all the time. So whilst you're here, you're learning about your subject, but you're learning about the wider academic world. And I think that's just been priceless.
Yeah. Wow. Such a lot of significance for embarking on this journey. If I could remember what you've actually talked about the methodology, your understanding and the skill set to, and even the vocabulary to talk about your subject area, the connections and the variety of things, opportunities that come your way. Let's go back to the methodology.
Okay.
I'm curious, what method are you using? What research question are you answering? And how are you collecting your data set?
Right. Okay. So my question at the moment, obviously in the PhD, your questions will change as you go forward. But right now, I am examining the impact of attacks against healthcare in armed conflict using a systems approach. And for me, I'm using, it's mixed methods. So qualitative interviews of patients and also experts and subject matter experts. I'm also doing workshops, so analysis of workshop material. And I've also looking at medical data, and that will be descriptive statistics of medical records of patients. And I'm also examining surveillance data on actual attacks. So I have data that I have access to, which is related to specific attacks against healthcare. And so that is a more qualitative approach to that analysis, because it's audio data. So I'm doing qualitative analysis on that. So there's a mix, depending on what the data set is. It's either qualitative, if it's in interviews and audio, and workshop.
Okay.
And it's quantitative with the medical records that I'm getting, and I'm going to just do that as straightforward.
Do you have to travel to the conflict area?
Well, I'm going to Jordan, and that's not a conflict area, but it's an area that has received a number of people who have fled armed conflict settings. So there's a high number of refugees there, and I'll be speaking to them about their patient journeys. And I'm specifically looking at cancer patients. So cancer patients who have who originally from an armed conflict setting, but who are forcibly displaced, i.e. they've had to leave, and they are now in Jordan, either living within Jordan, within an urban setting, integrated into the community, or if they're living within refugee camps.
So all the data will be on Jordan, or there will be other focus
the
areas?
qualitative data on the patient histories will be based in Jordan. The patients will be from Syria, from Palestine, from Yemen, from Iraq. There'll be patients that are all part of a single hospital that I have access to, called the King Hussein Cancer Centre. I'm working with them, and it will be the patient's journey of their cancer story, where they came from, why did they leave their country, were they worried about threats against healthcare there, was their healthcare disrupted? So a whole host of just trying to understand it. They are semi-structured interviews with this cohort, this patient group. I will also speak to staff about their journeys.
That's the expert.
So exactly. So the subject matter sort of specialists, healthcare workers, but some of these healthcare workers will have been refugees themselves, so they may well form a separate category. And then I will be, so that's the interviews, and then I will be looking at surveillance data of actual attacks, and that's surveillance data of audio airstrikes. that's something that I've worked hard to get hold of, and I have that, and I will be analysing that.
I'm curious, how did you get these data sets?
That's something I can't talk about.
Okay, confidentiality in the research. All right, you mentioned something about triangulation. What is it, and
So it
how
means
you? Yeah.
that means data that is it's like a Venn diagram
Mm-hmm.
where you have this set of data,
Yeah.
you know, this category,
Mm-hmm.
and then you have the other category, and then and then you begin to see overlaps.
Oh, yeah.
And then there'll be something in the middle where it all overlaps. And for example, one example it will be and bearing in mind the question is understanding the impact of attacks against
Exactly.
healthcare. So, within the central bit, I don't know, it could mean that, because at the moment I'm still on that journey. What are the intersecting points of all of the data that we're finding?
Yeah.
Is it because, and I'm not prescribing this,
Mm-hmm.
this has to come from, for example, the people that I'm interviewing, it has to
Yeah.
come themselves. Do they say that what they witnessed the most was attacks against healthcare,
Mm-hmm.
which led to delays in their treatment? They might not, it might not be, I'm just assuming that at the moment. They might say it was, the infrastructure was really bad even before the war, and, it was too dangerous to stay generally, so we moved. And then as we moved, I realised that, I needed to go and get myself checked out, and, I did that in my host country. Or they might say that, there was a war, there was no time to think about your own health. It's only when I settled in my new country that I began to think about my health. I don't know what they're going to say yet. I don't know what their journeys are. That's what I'm trying to learn. So in that central triangular bit where everything overlaps, and try and build an understanding of all the intersecting and even the standalone areas,
Mm-hmm.
I'm hoping that this will, I feel it will be like almost like putting a jigsaw puzzle together. That's what I think will happen by looking at will something from the workshops, and the workshops are experts in this field,
Mm-hmm.
will the workshop material offer me information that will reinforce what the patients had said in their interviews? They might say, as subject matter experts, we know that there are, attacks against healthcare there were in Syria. And then the patients will say, yeah, we came from Syria, and the hospital next to where I lived was bombed. That's a bit of like putting things together.
Yeah.
It's a bit like corroboration as well.
Yeah, I get you. All right. So I'm sure that as I'm curious, others are curious as well. Could you tell us the preliminary findings that you have now?
Oh, right.
If it's not confidential.
No, it's not. I think at the moment the preliminary findings are, so we've done some workshops already,
Mm-hmm.
done some interviews. I think attacks against healthcare, and this is a worry that I had when I began my PhD. I thought, am I going to spend 4 years stating the obvious, that attacks against healthcare in armed conflict is a bad thing? You don't need to spend 4 years doing that. No one's going to say it's a good thing. But I think it was the detail of it that I wanted. It was and at that point, I had no idea that the world was going to go mad and on fire, and where it is now, where
so much conflict nowadays.
So much conflict now, and so much. I think my preliminary findings, if you like, is that it almost points to a strategy with the conflicts that we're seeing right now, that to exploit healthcare right in the beginning. So rather than it being collateral damage, rather than it being we had no choice, we had to go in, we had to bomb this hospital because they were hiding weapons there, whatever. There's not even now, from the interviews that I'm doing, there isn't even a pretense to have that as a reason to do it. It's now in the most, even in the last year, whether it's Sudan, Ukraine or Gaza, there's no kind of, oh, we did it because, it wasn't us, it was them, or there is, we had to go in because they were hiding weapons in there or whatever. That now isn't even a narrative that you're hearing. You're just hearing that a hospital was raided and bombed. You're just hearing that doctors were dragged away and killed and nurses. You're just hearing of an entire hospital with its patients killed. We heard about the horror in Sudan.
Yeah.
There's no explanation. It's just happening.
Yeah.
And in Palestine, it's happening. In Ukraine, in one of my interviews, I learned that healthcare workers are military healthcare workers are removing their Red Cross emblem when they go into a battle area, because they know that they are, together with leadership, so anyone that's wearing officer status on their shoulders or a Red Cross emblem, they have, in my interviews, I've learned that those two groups feel that they are the first to be targeted in a sniper's sights, so they remove those. So there is now, my preliminary finding is that the healthcare workers appreciate and understand, and again, it feels a bit silly saying this, I think everyone can see this now, that healthcare workers know that they are targets, that their protection doesn't feel so robust anymore, that international standards are not protecting them, and that that there is now consideration about a change of practice about, do we wear the emblem or do we not? So that's very rough preliminary findings at the moment.
Yeah. So if you are to advise a healthcare minister or the director of, or the CEO of Red Cross or an emergency medical service, what would you say?
I think with the International Committee of the Red Cross and the Red Crescent, this is their area. This is what they know about. They are an entity that combine healthcare and law, so they'll know this, and they will be the ones that will probably be doing the advising. But I think in what I would tell them about my findings is that that they might not already know, is about the impact of delays, how the scale of impact delays on access to healthcare caused by destruction. What does it mean in real terms to a patient? What's the quantity of late diagnosis? That's what I'm hoping to have by the end of this. Put a figure to it, where 50, 60, 70% of patients who presented were for the first time with cancer presented at stage 3 or 4 with metastases. That's what I don't know if that's my finding, but that's the kind of narrative that I'm looking for. I want to be able to explain to the senior policy people, this is what the scale of this is. This is the dire outcome on the patient at the moment when you have this unchecked, continuing attack on healthcare. And I also I'm very passionate about other chronic illnesses. It might be something that I'm hoping to look at in my postdoctoral world. So I want to look at other areas of healthcare, emergency medicine, because I'm an emergency medicine doctor, but also renal disease. So patients with end-stage renal disease. I want that I'm learning, even though my focus is on cancer, I'm learning about the utter dire situation of people who have end-stage renal disease who need dialysis. And dialysis machines are few and far between. They require specific types of filtered water. They require electricity to run. And I've learned about techniques that people are using to keep a machine going, keeping it operating all night so that patients can come. It's awful. So, I think I'm at the beginning of this journey. The PhD is just opening the lid. You know, I know that the real meat of what I want to do will probably come after the PhD.
Yeah.
But I think in terms of, you know, what I would like to say, that my current findings are that people are, that and this is the it's, I don't know if it's scientific, but, you know, the other outcomes that are emerging is concern about the lack of accountability. How are we going to stop this?
Yeah.
So this is the theme that's emerging in my interviews: the lack of accountability, the lack of any justice for those that have suffered as a consequence of attacks against healthcare, the long protracted road to accountability and justice. So there is a need for that.
All right, we're coming to the conclusion section of it, but now to ask you about your PhD journey. How has this PhD changed the way you see conflicts and, you know, medicine, or even within yourself?
Oh, I've really loved it. I'm panicking that I've only got 12 months left.
Yeah.
I really don't want this to stop, and I'm trying to think, how do I keep this going? Because I think it's only just started. I thought I knew a lot about armed conflict. I thought I knew a lot about armed conflict in health and healthcare delivery. I've worked in multiple places with different organisations, either NGOs, but also where I found the most value, if you like, for myself and insight was working with nationals of the country within their own settings. So, for example, in Libya, I was in Libya for about 14 months during the war, and in Syria for about a few months with local people. So working in their hospital settings, not an external NGO, but like within them. And I learned so much. And I think I thought I knew a lot, but the PhD made me realise that I knew very little, actually. And I might have focused knowledge on that one little experience that I had, and I can tell you a lot about what I did on that day, the patients I saw, you know, the aftermath of a mass casualty situation.
Yeah.
I can tell you in forensic detail about that. I can't tell you anything more. And I wanted to be able to talk about more. I wanted to talk about the multifaceted problem. And this goes back to the system.
Yeah.
It isn't just that place in that particular time. With health, for example, in Syria, healthcare attacked and destroyed in Syria meant that there were, and then war wounded were piling up. Chronic illnesses weren't being having access to care. Women who were pregnant needing maternal care, newborn babies needing that care. What that ended up doing was impacting another system, another healthcare system. It impacted Turkey because you have mass movement
to Turkey.
So what I learned on this journey was that I'm only at the beginning of really understanding all of this, and that this is going to be a subject that I'm going to be looking at for the rest of my career and the rest of my life, really. It's not going to stop.
Yeah.
And I've only just scraped the surface. And it's coincided with it really becoming a big subject, sadly, because of what we see going on around us.
Well, your PhD seems a bit very heavy emotionally. How are you protecting yourself?
It's a very good and very kind question, Sam. Thank you. I think I'm a little bit. It's not impacting me that much at the moment, and I sometimes think, why is that? Have I become desensitized to it? And that's a worry. And you think, no, but I think it's because of my background. Because my year at Sandhurst, I was Sandhurst trained officer, was incredible. It was one of the best years of my life in terms of training and future-proofing me for what I did next. So that was brilliant. lessons that I learned, things that I learned then have stayed with me throughout my life. Secondly, working as an emergency medicine doctor in the UK has been very hard.
Yeah.
And but it's a team effort, and I love working with my colleagues in emergency medicine. So that helps you, and there's always some in that space. It's helped. I've worked also in different settings where, you know, the injustice of what you see in terms of healthcare delivery kind of has helped strengthen me. But I think it's because of what I've seen then that is driving me to do what I do now.
Yeah.
And that makes me not dwell on what I'm seeing now, because I feel that there's an urgency. So I don't know what it's going to feel like at the end. Believe me, there are lots of ups and downs.
Yeah.
There are a lot of times where you just have to stop and you just like, you know. But I have a support network. I have my family. I have my friends. I have different supervisors around the university. I've cried in many offices. I don't mind saying.
Yeah.
It happens.
The PhD makes you cry sometimes.
It does. I don't recognize myself. I seem to be crying quite a lot these days.
Yeah.
But I think the journey for every PhD student is going to be different, and it is intense. And I would, in terms of what I would suggest and recommend, is find your mentors. It might not be your supervisor. It might be someone else. But if you can find people around the university who you share an interest with in
Find
your
your clan.
subject, find your find your group, find your people, find the people who are passionate about your subject in the way that you are, and even finding like a supervisor, someone who is more a mentor rather than a supervisor, is what I have done. And I'm indebted to people around this university who have given me time and mentored me and have said, come in, and I have sat there and cried. And I have got it out in that space, and we've talked, and I know it's a confidential conversation, and they can sometimes, because of their experience and knowledge, and they can see beyond the PhD, because us at the moment, the PhD is our life, but they knows what the journey is next. And the PhD is a time when you care so passionately about what you are studying, you know, you're protective about it. It's like your child, you know, and any disruption on that, or anything happening along that journey can make you panic and feel worried. So having people that it might be your faculty advisor, it might be someone, make sure you've got someone you can go and speak to. And there's the welfare people within your college are excellent. I've used I've used them a few times. It's brilliant. And then what you realize is that you're not the only one that's feeling like this, because you think it's just you, and then they know, no, there's so many people that feel the same.
When I started my PhD, my supervisor told me, Sam, I'm not the only one to advise you on this work. You have your colleagues, you have other PhDs, you have the postdoc. Have conversations with people in your colleges, and you'll do well. Yes,
that's amazing advice. That's amazing advice. And I think, you know, I know that sometimes the student-supervisor relationship can be a challenging one, and that's apparently part of the process. But it's about finding other people as well, and not being stuck in your own head, thinking it's just you. And that's how I've done it. I've reached out.
Okay. With this section, I'm going to bring a set of questions. I'm not going to ask you, but you are going to pick and then choose one of it, which you pass it to me, then I ask you. Yes. Okay. There we go.
I like
What could this be? What's one habit your PhD has forced you to build?
Right.
Well, you could also explain why.
A habit.
Yes.
Do you know, I used to be terrible at this, really terrible. And I never used to do it. And people might think, well, that's just such an obvious thing. But I literally now enter things into my diary and my calendar immediately.
I've been doing that as well. I've been keeping a journal.
I never used to do that. I used to go, I'll remember that. I'll remember that. Now, if someone sends me an email that says this event or whatever, rather than me going, I'll sit down and have a coffee and read all my emails, it goes into my Outlook right then and there. If someone says, sends a message to say, have you got time for a meeting tomorrow at 2:00? I will be the one, because if I don't do it and they've suggested it, and then I just take ownership of sending that Teams invite. So that's a habit that I've developed the hard way.
Yeah.
After many missed embarrassing meetings that didn't happen or whatever, and running between Outlook and my paper diary. And so that kind of ties in the fact that I now have transferred from an analog paper diary to my
a digital.
Outlook.
Yeah. All right. Thank you very much. That brings us to the end of the first episode of the ViVa. A huge thank you goes to Saleyha Ahsan for sharing her research with us, and then for telling us what she does in understanding the impact of armed conflict on the healthcare system, and looking at this from a systematic point of view. Well, I'll try to summarize some of the things that, I got here. Methodologically, it helped you to understand issue from a different point of view. And then the evidence that is coming out is really interesting, and how the armed conflict is affecting people in terms of, access to healthcare and then early responses to healthcare. What you've learned so far is also to find your people. Find a group, and then and that's your key advice to PhD students or people who are doing postgraduate education, and then also keeping a journal or a calendar. Thank you very much.
Thank you, Sam. Cheers. Bye.
All right. Special thank you also goes to Isaac Apia, who will be editing this video, to Pixabay for the sound for this podcast, and also to everyone who is listening. If you are curious, please like and subscribe to this podcast, and see you next time. Bye-bye.